Shamoon, can you hear me? Can you see me?
Yes, ma'am. Yes, ma'am.
Okay, so good afternoon, everyone. I am Dr. Khushboo Ghanshyani, working as a consultant pathologist here at Vijaya Diagnostic Center. And today we have with us Dr. Shamoon, who is also a consultant pathologist at Vijaya Diagnostic Center, Hafsiguda branch. Dr. Shamoon is going to talk with us today about the role of FNAC in palpable thyroid lesions. Thyroid FNA is one of the most common procedures encountered by a cytopathologist, and due to its rich vascularity, proximity to close vital structures, and tendency of multiple lesions to coexist at once, technical expertise is of utmost importance while doing the thyroid FNA. And that is what Dr. Shamoon is going to talk with us today about. So without taking much time, I invite Dr. Shamoon to enhance us with her experience and knowledge in the field of thyroid cytology. Over to Dr. Shamoon.
Thank you, ma'am. Good evening, everyone. Today, I'll be talking about role of FNAC in palpable thyroid lesions. These are the contents of my presentation today. I'll quickly brief you about the topics, that is introduction, the indications for FNAC in thyroid lesions, then the method, how we do it, followed by complications, if any. Then I'll discuss about the adequacy of the sample received or obtained upon FNA. Then what do we diagnose using that material? That is classification of various thyroid lesions. Then how do we report it? That is the Bethesda system for reporting thyroid cytopathology 2023 edition. Then I'll also discuss the ancillary tests done for thyroid lesions with their indications, and also lastly the limitations of thyroid FNA. Coming to the introduction, what is FNAC? It is a technique whereby the cells are obtained from a lesion and smears are made for cytopathological diagnosis. This is done based on the fact that tumor cells are less cohesive and are easily aspirated. It is a simple, quick, and inexpensive technique. It is performed as an outpatient procedure, and the investigation of choice for thyroid nodules is FNA. USG guidance increases the accuracy of diagnosis in thyroid FNACs. Then, what are the indications for thyroid FNAC? It is indicated for the evaluation of solitary thyroid nodule, either benign or malignant, then evaluation of diffuse thyroid lesions, confirmation and categorization of thyroid malignancies. Then it is indicated for obtaining material for ancillary test or prognostic parameters. It could be indicated as serial FNACs for long-term monitoring, detecting changes in nodules over a period of time, and ensuring timely intervention if malignancy develops. Coming to the method, we examine the patient in upright position as it is located in the neck region. Then the patient is made to lie down in supine position with pillow under the neck, and we instruct the patient to refrain from swallowing or making any sort of noise. Then sterilize the site and introduce a needle of usually 23 to 25 gauge through the skin. The lesion is needled back and forth 6 to 8 times. In various rotational directions. Then we stop needling as soon as we get material in the hub. Then apply gentle but firm pressure over the site to avoid hematoma formation. Most commonly used stains for thyroid FNA are MGG or PAP. We also use HND. USG guidance is recommended in case of non-palpable thyroid lesions as it enhances the adequacy or the material obtained. Complications of thyroid FNA include minor hematomas, which need to be informed to the patient before the procedure itself, and rarely we might puncture the trachea or carotid artery or jugular vein, so we need to be very careful while doing the procedure. Now let us see what is the adequacy criteria provided by Bethesda 2023. There should be at least 6 groups of well-visualized thyroid lesions, well-visualized thyroid follicular cells, at least 10 cells in each group, and preferably on a single slide. There are few exceptions to this, like solid nodule. A sample that contains significant cytological atypia is never considered non-diagnostic or unsatisfactory. It is always satisfactory and should be reported. And like nodules in lymphocytic thyroiditis, abscesses, granulomatous thyroiditis, they may only contain inflammatory cells such as uh, inflammatory cells, and such cases should be interpreted as benign, and a minimum number of follicular cells is not required in such cases. And also the samples or specimens which contain abundant thick colloid are also considered benign, and they should be reported as colloid nodules. Let us see what we diagnose using that material. That is classification of thyroid lesions. They are classified as non-neoplastic and neoplastic. Non-neoplastic thyroid lesions include colloid nodules and inflammatory conditions like acute, chronic, subacute thyroiditis, and also Riedel's thyroiditis, where we see fibrosis of the gland. Coming to neoplastic lesions of thyroid, they are benign and malignant. Benign ones include follicular tumor or Hurthle cell tumors, and the malignancies like papillary carcinoma, medullary carcinoma, anaplastic carcinoma, lymphoma, sarcoma, and metastatic cancers. These are the 6 categories given by Bethesda system. Category 1 includes non-diagnostic or unsatisfactory lesions. Then category 2 includes benign lesions. Category 3 includes ATP of undetermined significance. Then comes category 4, which includes suspicious for follicular neoplasm or follicular neoplasm itself. Then is suspicious for malignancy, category 5. Then lastly, the malignant ones, which fall under category 6. Let us see in detail what lesions are included in each category. Coming to non-diagnostic or unsatisfactory category of Bethesda system, a few conditions like cyst fluid only if it is obtained by FNA, or virtually acellular smears, or others like clotting artifacts, etc. I'll show you in the following images. The first one here is showing the follicular cells which are obscured by hemorrhagic background. So here the diagnosis is not possible. We categorize it under category 1. The second image here is showing um, again aggregation of skeletal muscle fibers only, and there are no follicular cells. Again, this falls under category 1. The third image is showing hemosiderin laden or foamy macrophages, and there are no follicular cells again. And the last image is showing aid-dried follicular cells with obscured nuclear layers. These all fall under category 1, where it is considered non-diagnostic or unsatisfactory. The second category includes benign lesions like benign follicular nodule or which includes adenomatoid or colloid nodule. Then lymphocytic thyroiditis, also Hashimoto's, and consistent with granulomatous thyroiditis as well. I'll show you the images. The first image here is showing thick colloid with cracks and sparse follicular cells, may also contain colloid-laden macrophages. It is diagnosed as colloid nodule and falls under category 2. The second image is showing follicular nodule. As the name itself is suggesting, it contains cells arranged in small groups or circles called follicles. And the third one, clusters of oncocytes and many lymphocytes in the background. Chronic lymphocytic or Hashimoto thyroiditis, which falls under category 2. Let us see what is category 3 of Bethesda system. Includes ATP of undetermined significance. If the smear contains cells with nuclear ATPR that is not sufficient to be classified as suspicious of follicular neoplasm or suspicious of malignancy, then it falls under category 3. There is possibility of papillary carcinoma which cannot be ruled out, so we put it under category 3. Sparsely cellular aspirates comprised of follicular cells with architectural ATPR and where the colloid is absent also fall under this. These are the 3 images which fall under category 3. Let me show you. Image 1 is showing ATPR of undetermined significance, showing architectural ATPR. It is difficult to distinguish follicular neoplasm from goiter. The second image is also ATP of undetermined significance, where you can see lymphoid cells which are showing nuclear ATPR. And the third image is showing ATPR or molding and grooves in nuclei due to drying artifact. These are all the examples of category. Category 4 of Bethesda system includes follicular neoplasm or suspicious of follicular neoplasm lesions, where cases which show significant architectural atypia, predominance of microfollicles, or crowded groups. These raise the possibility of follicular carcinoma. Follicular and Hurthle cell neoplasm both come under this. You can see the image here. The follicular neoplasm, small follicular follicles composed of cells with nuclear enlargement and hyperchromasia are seen. Category 5. This includes the lesions which are suspicious of malignancy. That malignancy could be a follicular variant of papillary carcinoma or a papillary carcinoma itself, or medullary carcinoma, metastatic carcinoma, or a lymphoma. Here the image is showing suspicious of lymphoma. Sixth category includes the malignancies of thyroid gland. The first image here is showing papillary carcinoma thyroid, which is, you can see a intranuclear cytoplasmic inclusion here. As we all know, the very famous name given to these nuclei is orphan Annie-I nuclei. I would like to share why they are called orphan Annie-I nuclei, because the nuclei they look optically clear with trimming of chromatin towards nuclear borders and a central clearance, as we all know. This is more appreciated in histopath, but we can also see those inclusions in FNAC or cytology smears. Here, this name was given based on the comic series, an American comic series which was famous during the 1924 to 1927 years. And this cartoon was famous, and she has, no pupillar iris and clear looking eyes. So, based on that, the name was given orphan Annie eye nuclei. The second image here is showing medullary carcinoma, and the third image is showing anaplastic carcinoma. The medullary carcinoma image, you can see eccentric nuclei and salt and pepper chromatin. And this small image here in it is showing positivity for calcitonin or immunostate. The last one is anaplastic, as I said, with variable shade cells with enlarged and active mitosis. Now, let us see the recommended management in all these Bethesda categories. If the lesion falls into category 1, the recommended management is repeat of FNAC with USD guidance. And clearly, there is no risk of malignancy because we are unable to diagnose it itself. Then the second category shows clinical, clinical follow-up is indicated, and if advised, repeat FNA under USG guidance. It has 0 to 3% risk of malignancy. ATP of undetermined significance category 3 also asks for repeat FNAC or follow-up with 5 to 15% of risk of malignancy. Then category 4 follicular neoplasms or suspicious of follicular neoplasms require surgical lobectomy, and they have a little increased risk of malignancy, like about 15 to 30%. Then the lesions which are already suspicious on FNA require near total thyroidectomy and have 60 to 75% of malignancy. And lastly, we diagnose it as malignant on FNA and it requires total thyroidectomy, and on histopath it might turn out to be 97 to 99% malignant. Let us see what are the ancillary techniques which are used in thyroid tumors. There are certain special stains like Congo red or immunohistochemistry like one second. Immunohistochemistry like cytokeratins, etc., and flow cytometry for detecting, tissue factors and enabling diagnosis. Then molecular genetics for mutations in various pathways like BRAF mutations, PI3AKT, etc., etc. And what are the indications for these ancillary tests? They include the diagnosis of primary thyroid malignancy like papillary or medullary carcinoma, or the diagnosis of a metastatic tumor in thyroid, or the diagnosis of parathyroid lesions. All these require ancillary techniques. Let us see the limitations for FNAC, thyroid FNAC. This technique cannot differentiate between follicular adenoma and carcinoma. And the needling may convert a hot nodule into a cold nodule or a cold nodule into a hot nodule. Therefore, all non-invasive procedures, TFTs, etc., should be done before FNAC procedure itself, because it might sometimes lead to false positive results as well, like Hashimoto's and Graves. Coming to the conclusion of my topic, FNAC is considered the gold standard with high yield and cost effective procedure in pre-operative evaluation of thyroid nodules, mind you, in pre-operative, because in post-operative cases, histopathological examination is the gold standard. And when it is combined with ultrasound guidance, it has higher sensitivity and specificity in providing accurate information, which can be used for management of thyroid nodules. Although it is safe, reproducible, and cost-effective method, it can result in false negative reports sometimes. So, in future, we have a scope of improving, improving the diagnosis of thyroid lesions using FNA and ancillary tests. That's what we had to say. We are open for questions, if any. Thank you.
Okay. Okay. Thank you, Dr. Shamoon, for such an insightful presentation. So, I would like to add a few points to what you have already said. You said that ultrasound guidance enhances the yield. And as you rightly said, in our practice, whenever there's a smaller lesion or a deep seated lesion, or even in case of palpable lesions, when the lesion is heterogeneous or highly vascular, we encourage ultrasound guided procedure to prevent hemodilution and also sampling from the accurate site. And you have spoke about the Bethesda system. Similarly, in various parts of the world, there are different systems followed. Like, for example, the RC-PATH system in the UK and Europe. So the category terminologies are different, but essentially the risk of malignancy and triage of the patients is more or less the same. So I just wanted to make a note of that. And you rightly said molecular studies are possible on the fine needle aspirate, and the specifically the BRAF V600E mutation that you have told about, that test can be used to detect and diagnose the papillary thyroid cancers even pre-op, especially when the cytological diagnosis rendered is indeterminate, like ATP of undetermined significance or follicular neoplasm or suspicious of follicular neoplasm. These lesions, even on frozen section, they cannot be reliably differentiated from the malignancy. So that time it creates a dilemma for the surgeon whether to perform hemithyroidectomy or go for a total thyroidectomy. In that
Right.
case, if a pre-op BRAF V600E testing has been done on the FNA aspirate and it is conclusive, then it makes the life easy for a surgeon. So these are the
Right.
few things I would like to add. But otherwise, thank you. That was a good presentation.
Thank you,
And
ma'am.
now let us look if we come across any questions or. So I don't see any questions coming up. So I think we can conclude the session then. Thank you, Dr. Shamoon, and thank you, audience, for being with us.
Thank you so much, ma'am.
Yes.